Uh, Welcome, dear colleagues and students from intensive care, medicine, radiology, or whichever field you are from. So today we are going to be learning chest CT, and chest CT will be confined to the ICU, what we see in critically ill patients. And we have a very senior and eminent speaker today. So it's Dr. Rajesh Gothi. Sir is a senior consultant in radiodiagnosis at Holy Family Hospital currently. Previously has been in many hospitals. And he has been the organizing chairman for oncoimaging, has more than 80 publications and lectures in various conferences, and he is distinguished awardee in the field of radiology, getting the GP Lal Award, the GSC Bose Award, the Chikitsa Ratan Award, and Distinguished Service to IRI Awards. So, sir is a very eminent radiologist, and I'm sure it'll be a very good learning for us, something which we rely upon the radiologist, and it's a good learning CT for us also. Thank you, sir. Please, all yours.
Okay. Good evening. I'm Dr. Rajesh Gothi. As I have been introduced, thank you very much for the introduction. So let us start with my presentation. What I intend to do today is that I want to discuss with you the pathology as well as anatomy during this presentation. And I hope that at the end of the presentation, you would have learned something. So we'll start with the query first. In this particular case, there's a 67-year-old female with shortness of breath. My question to you is, would you call it cardiomegaly from this X-ray? If we take the measurements, maybe you will say that the cardiothoracic ratio is increased. But actually, X-rays are very deceptive, because this X-ray is actually shows a mediastinum which is a mixture of fat and the cardiac shadow. And I'll show you what I mean by that. This is the cardiac shadow, and the rest of it is all fat. So whenever we talk about cardiomegaly, we presume that the whole thing is made of the heart, but that is not true. The entire mediastinum is not made of simply of the heart, but it has got other structures also which add up and then produce this picture. So you should be very careful when you call anything as cardiomegaly, because it may not be true at all. Now, the same patient, in this patient, we are seeing the patient was admitted with shortness of breath, and we are seeing these two images. These are expiratory films. Why am I calling the CT scan as an expiratory film? It is because if you look at the trachea is C-shaped. This cartilage over here, this ligament over here is pulled inwards. So when the ligament is pulled inwards, it implies it's an expiratory film. The patient had shortness of breath and there was air trapping. Now these are the areas of air trapping. Areas of air trapping are more lucent than the rest of the lung parenchyma, and there is a paucity of vessels in these areas. And there is also evidence of bronchial wall thickening in both lower lobes. So a combination of bronchial wall thickening and areas of air trapping in an expiratory film makes it suggestive of a small airways disease, which could even be acute HP, hypersensitive pneumonia. Now we'll come to some cases. There's another case now. 90-year-old female, influenza A positive. Here's the chest X-ray. The cardiac silhouette. I don't call it the cardiac shadow. I call it the cardiac silhouette. The cardiac silhouette is prominent. The lung fields are hazy. In the CT scan, you can see that there is ground glass haze here in the right upper lobe. The lower lobe shows an area of consolidation, and there is some amount of ground glass haze in the left upper lobe also, which you can see here in the coronal sections. And if you go back to the X-ray, you'll find that the right diaphragm is looking very sharp as compared to the left. Now, why is it that the right diaphragm is looking sharp? The right diaphragm is looking sharp because the patient is not able to take a deep breath over here. The breathing is mainly from the left lung. So because there is an inadequate breathing activity in the right lung, the diaphragm does not move that much. Therefore, the outline looks sharp. And if you compare it to the opposite side, the diaphragm is blurred because most of the breathing activity is taking place over here. If you will see, there is an endotracheal tube the patient is supine and the breathing is mainly from the left lung, not from the right lung. That is why the diaphragm is sharp and the disease is also more in the right chest. There is also a small amount of pleural effusion. So whenever you come across a case of influenza pneumonia and you find that there are lung lesions but also pleural effusion, think of a superadded infection. So that can be the reason why the pleural effusions develop, because most of the times in viral infections, pneumonia is not so common. Coming to another case, 81-year-old female, a case of influenza A infection. What are we seeing here as findings of typically of that of a viral infection? We are seeing bronchial wall thickening in both lung fields. Again, expiratory film. It is also possible that the patient is not able to take a deep breath. There are areas of ground glass opacities in both lung fields, as well as in the, and in fact, in the lung fields, they are distributed at different places. So this differential distribution or differential distribution in different areas of the lung parenchyma is suggestive of a bronchopneumonia. And there is a bronchopneumonic pattern with thickening of the bronchial walls, a finding which fits into the diagnosis of influenza pneumonia. Coming to the next case, an 84-year-old male brought in emergency in a collapsed state. The patient had a history of dengue fever. Abdomen was distended. The patient was intubated in the emergency. Lab data was showing a normal electrolytes, except for thrombocytopenia, and it fitted into the possibility of dengue fever. An X-ray chest was done after intubation, as well as an X-ray abdomen. Now the chest X-ray shows haziness in both lung fields, and in the abdominal X-ray, you will see that there are dilated bowel loops. Now, if you are talking about a patient of dengue fever, you can expect findings in the abdomen as well as in the chest. They are generally due to fluid overload. They are generally due to involve serositis. So, but in a serositis, why should the bowel loops dilate? That was a rather unusual finding. So, a CT scan was performed. Now, in the CT scan, if you look at the esophagus is distended. There is an endotracheal tube inside, the NG tube. There is bilateral pleural effusion. The left lung shows evidence of consolidation with an air bronchogram. The right lung shows presence of pleural effusion. If you now observe again, the fluid has a different density as compared to the consolidation. So we can all easily distinguish, even on an NCCT, effusion from consolidation. So we were having a patient who had a right pleural effusion, left lower lobe consolidation, and a distended esophagus. On a lung window, sometimes it is very difficult to distinguish between effusion and consolidation, but a mediastinal window clearly shows the difference between the densities of the two areas. Consolidation is denser as compared to the effusion. This patient also had a stent. So there were findings in the chest of right pleural effusion, consolidation, a stent, and a dilated esophagus. But what about the abdomen? So in the abdomen, why was the bowel loops distended? So when we were looking at the abdomen, we found that there was inguinal hernia which had obstructed. So there was an obstructed inguinal hernia causing distension of the bowel loops. There was hardly any fluid in the peritoneal cavity. Therefore, this patient now had two problems. He had a distended esophagus filled with fluid, so he could be aspirating. He had right pleural effusion. He had dengue fever. He had thrombocytopenia, and he had an inguinal hernia which was obstructed. So consequently, what happened? And if you look at the bones, you will find that the vertebral bodies are actually climbing one on top of the other. This kind of a picture where you are seeing two or three vertebral bodies in one section implies that the patient has got kyphosis. So he was a kyphotic patient. He had chest wall deformity. He had right pleural effusion. He had left lower lobe consolidation. He was probably aspirating, and he had an obstructed inguinal hernia. Unfortunately, we could not save this patient, and he expired after a few days. So there are so many findings that you can see on an X-ray and a CT scan, and it is very important that you look at all these findings very carefully. Another patient now, a 95-year-old lady, presented with fever and cough. The chest X-ray again does not show you too much. Most of the times X-rays help, but sometimes they don't. But when they don't help, you have to go for a CT scan. So we are seeing over here patchy areas of ground glass opacity and right lower lobe consolidation with air bronchogram. There is slight haziness in the left lung field also. Okay, so we are now looking at ground glass opacities in the left lung and consolidation in the right lung. The ground glass opacities generally implies that there is a air involvement. This patient also had coronary artery calcification, so the patient could be having aortic calcification, so the patient could be having coronary artery disease. Now let's look at this movie over here. So we'll go slowly. This is the trachea. That is the esophagus. The esophagus is distended and filled with air. We are seeing an area of ground glass opacity in the left upper lobe. So, one second. The ground glass opacity is patchy. You can see it distributed in both lung fields. The esophagus is still dilated, and we are seeing right lower lobe consolidation. So this patient again has small airways disease and consolidation in the right lower lobe with a distended esophagus. Such a patient could be aspirating, and therefore you have to take care of this patient's aspiration problem also. Now, sometimes you come across unusual findings when you're doing a CT
Sir,
test.
may I ask something?
Yes, please go ahead.
Sir, small airway disease of what nature? COPD or something else? Bronchitis, bronchiolitis?
No, when we say small airways disease, it means that there is bronchial constriction. Whether it is due to infection or whether there is inspiration.
Okay.
So, small airways disease is a broad terminology. It tells you that anatomically the small airways are affected.
Right. Thank you.
Yeah. So now coming to this case, an unusual finding. Again, bilateral lung lesions. Ground glass opacity is in the periphery of the left upper lobe and right lower lobe. Left lower lobe consolidation. And there is another shadow over here. This shadow is close to the aorta. This is basically a ductus aneurysm. So very often you come across these kind of findings, and you have to understand what they are based on the anatomy. One could have thought of a lymph node. There's a large left para-aortic lymph node. But when you look at it carefully, it is actually merging with the aorta. So if it is merging with the aorta, it can't be a lymph node. It has to be an aneurysm. So even an NCCT, non-contrast CT scan, can enable you to understand the anatomy. You don't really need to give contrast to see the anatomy. A case of bilateral chest. Now this is another case. It's a case of bilateral chest infection, and there are a series of bedside X-rays which have been performed. The patient had respiratory distress, was admitted in the ICU. There are multiple parenchymal opacities in both lung fields, and they are going on increasing up to this place, up to this day. Then the lung becomes more lucent, and then again we start seeing these opacities. So during this time, the patient was hyperventilated by a CPAP so that the lung looked better, but actually it was not better. It was getting worse. And then you saw these opacities in the final X-ray over here. So one of the problems with CPAPs is that when you overinflate the lungs start looking better. This is because the anterior aspect of the lungs get the air inside them, and the chest X-ray is a two-dimensional imaging, and therefore it does not show you what is happening in the area behind the anterior part of the lung, and the lungs look lucent. So when the patient was correctly managed, then the opacification again came into picture. Now this patient had parenchymal opacities in the right upper and lower lobes and in the left upper lobe. On the left side, there was also a large pleural effusion, and we can see air bronchogram. Subsequently, a hydropneumothorax developed, and the fluid content went on increasing. Now, question to you is, why did he develop hydropneumothorax? Because if you put in a chest tube, you don't develop hydropneumothorax. You can see a few air bubbles. So therefore, it is not due to insertion of a chest tube or drainage of the pleural effusion. So what happened was, the patient had developed a pleuroparenchymal fistula. You can see very clearly that in the lung parenchyma, there's a break, and that is communicating with the pleural fluid collection, and a fluid level is formed. You can see it again here in this image also. These are the sagittal sections which show it very clearly. That is the pleural effusion. That is the lung in the sagittal section. You see areas of ground glass opacities because of airway involvement. And you can see this oblique fissure over here and the fluid collection posteriorly. Same thing here in the mediastinal window. There is the diaphragm and that is the effusion and the level. Besides having a pleural parenchymal fistula, the patient also had developed a bronchopleural fistula. You can see a bronchus communicating with the fistula, communicating with the pleural space. So this patient was, managed conservatively, and subsequently everything became all right, and he was discharged. So these fistulas can subside on their own without having to do any surgical management. Now, if you look at the diaphragm over here, this is the right diaphragm, and that is the left diaphragm. Do you see how inferiorly it has been pushed? The pleural effusion was actually pushing the diaphragm downwards. Now, very often we get these kind of cases. Patients have pneumothorax and a chest tube is inserted. So when we are looking at the scans, we can't see the chest tube. This is the anterior part of the chest with a pneumothorax. This is a collapsed lung. And so where is the chest tube? Now, if you come to this image, these are the vertebral bodies. This is where you are seeing the chest tube. I'll show you the magnified image. This is the vertebral bodies. This is the lung which is collapsed. And that is the chest tube. In the lateral view, you can see it's lying posteriorly. It should have been anteriorly and superiorly positioned, but it is lying posteriorly. That is why the pneumothorax is not draining. So you have to be very careful about it. So where your chest tube is going, and if in case you're not sure, there is no harm in repeating a CT scan, getting a CT scan done. Now, this is another case. The patient came with a history of trauma. You can see evidence of subcutaneous emphysema. There were multiple rib fractures. This was the X-ray chest on day 1. The right CP angle is blunted. You're not seeing anything else. The mediastinum is not shifted. But soon enough, the patient developed a large pneumothorax. This is a supine X-ray. You can see the mediastinum is shifted now towards the left. The left lung is hazy. The right lung is collapsed. And they have inserted a chest tube. There's a large pneumothorax, and you can see this pleural reflection over here. Now, if the chest tube has been inserted, why is the pneumothorax still present? So again, large pneumothorax. Now, another thing I want to show you here is this deep sulcus sign. You must have heard about a deep sulcus sign. In a supine X-ray, you can pick up a pneumothorax by looking for a deep sulcus sign. Air enters all the way into the bottom of the pleural space, and this pleural space over here, this pleural region overlaps the lung. So if by any chance you're doing a lung biopsy or anything, you have to make sure you can go through the pleural space and create a pleural effusion or a pneumothorax. So a deep sulcus sign is what we are seeing over here. So now this patient came for a CT scan because the pneumothorax was not draining. The large anterior pneumothorax. This is the opposite lung for comparison. This is the anterior part of the diaphragm, posterior part of the diaphragm, collapsed right lung, focal consolidation in the right lower lobe. This is the opposite side, small effusion. So we look for the tube. The tube is lying over here. It comes here, but doesn't go into the chest. So it is lying actually outside. You can see the tube lying outside. It is tilted, it is kinked and gone down. Now, I have found that when a patient has got an emphysema, very often it is difficult to place the tube right into the chest because of the thickness or swelling in the chest wall. So subsequently, after we had pointed this out, it was repositioned, and you see that the pneumothorax has been drained out. So this is the value of one of the important values of doing a check CT or a CT scan in these kind of patients. It really helps, when we can pick up these kind of misadventures, and the patient gets relieved by the subsequent management. Another case now, patient came with a history of stroke. A non-contrast CT scan showed a left MCA infarct. So when we were looking at the scan, it is a non-contrast scan. What I noticed was that the left internal carotid artery was dense. Now, why should the internal carotid artery be dense in an NCCT chest of the head? This was because there was an acute clot lying inside the left internal carotid artery. So we did a CT angiogram. I'm going to compare now the right side to the left side. That is the right external carotid, right internal carotid, left external carotid. The left internal carotid is partially thrombosed. There was an acute thrombus which we saw earlier on in the NCCT, this one. And this is what we are seeing in the CCT. As we went down, there was a thrombus in the left subclavian artery, and there were also multiple small thrombi in the right upper lobe pulmonary artery branches. So this patient had thrombi in the left internal carotid artery, left subclavian artery, as well as in the right pulmonary artery branches. So too many thrombi in too many places. So we did a pulmonary angio also. You can see this thrombus over here. Then when we are looking at the left lung, there is this kind of an opacity. So if you do only an axial scan, and if you see only axial scans, you can consider that this to be a tumor and maybe tumor thrombi everywhere else. So what we did was we looked at the coronal sections. Now in the coronal sections, the left diaphragm is elevated. And there's all fat over here. This is the fat. This is a mixture of fat and consolidated upper segment over here. This segment and the fat that have been taken in. And that is what we are seeing over here. You will also notice that the mediastinum is shifted towards the right. So what is this? This is actually eventration of the left dome of the diaphragm. It is not phrenic nerve paralysis, because phrenic nerve paralysis occurs due to 2 or 3 conditions only. Either there is a tumor, or there is a trauma, or there is some injury to the phrenic nerve or involvement of phrenic nerve. It's generally an acute problem, and acute problems can at the most elevate the diaphragm. They don't allow the abdominal contents to go up into the chest, because this is a slow process. It starts with gradual increase in the intra-abdominal pressure and then moves up into the chest. And when it does that, then it pushes the mediastinum to the opposite side. So whenever you come across a mediastinal shift in a patient with an elevated diaphragm, you think of eventration of the diaphragm. Both in eventration and diaphragmatic hernia, the diaphragms are thin. So thinning of the diaphragm does not exclude a diaphragmatic hernia. Neither does it include eventration of the diaphragm. It is only the shift of the mediastinum which tells you that you are looking at eventration and not at a diaphragmatic hernia. So this is what the X-rays look like. This lucency over here is due to the fat. Mediastinum is shifted to the opposite side. And that is what we found in this patient. This patient was 47-year-old and he had antiphospholipid antibody syndrome. Another patient now came with...
Sorry, sir, what syndrome?
Antiphospholipid antibody syndrome.
Okay. Eventration was accidental.
The eventation was, of course, incidental.
Okay.
Another patient now came with acute shortness of breath. PO2 at that time was 84%, and NCCT was requested. And in the NCCT, we are seeing what is called a reverse halo sign in both lung fields. A reverse halo sign means that the periphery of the consolidated area is dense and the central area is lucent, bubbly in appearance. So this reverse halo sign was earlier on described only with infections. But now we know that there are several causes of this reverse halo sign. And based upon these findings, one can consider, in this particular case of shortness of breath, acute infarcts and acute infection. There was also a lot of pleural effusion, which was slightly unusual for acute infarction. Normally in acute infarction, the effusion is small. The other interesting finding was that if you look at the cardiac shadow, the luminal contents are slightly less dense as compared to the interventricular septum. This means that the hematocrit of this patient is low. So the patient had a low hematocrit, he had bilateral reverse halo sign, and he had a right pleural effusion. The rest of the lung was all right. So we did a Doppler study. There were thrombi in the right common femoral artery and the long saphenous vein. This is a long saphenous vein. There is a common femoral artery, a common femoral vein. You can see the color Doppler, it doesn't fill up. And you can actually see the acute thrombus very clearly. The distinguishing feature between an acute thrombus and a chronic thrombus is that in an acute thrombus, the vein expands, and in a chronic thrombus, the vein is actually small in size. Sometimes, you may not be able to see the thrombus at all in an acute thrombus, and then you have to actually compress the vein. And if the vein does not compress, then you know that there is a thrombus sitting inside the vein. We could see the thrombus over here by adjusting our gaze, and that is what the thrombus looked like. So this patient had a thrombus in the lower limb, and the patient had reverse yellow sign, and he had presented acutely. So we thought that this entire thing in the lung is possibly because of acute thrombi causing infarctions. So then we went in for a CTPA. In the CTPA, that is the aorta, superior vena cava, right atrial appendage, aorta, the branches of the pulmonary artery, right, main pulmonary artery, right pulmonary artery, left pulmonary artery, descending aorta, branches of the aorta. So there is no thrombus. But what we can see is that the right atrium is larger as compared to the left atrium. The right ventricle is also slightly more, as prominent as the left ventricle, I would say. So there is increased pressure in the right heart. And you can see these ill-defined parenchymal opacities in both lung fields. So there was no thrombus. So, but we knew that there were thrombi in the lower limbs, and we could not demonstrate any peripheral thrombus, which is possible. So what do you do in such cases? So in such cases where you're not able to see thrombi, but you have a very strong suspicion that it is because of a thrombotic phenomenon, you can either do a VQ scan or a dual echo CT scan with an iodine map to be able to pick up areas of hyperperfusion. So that is what should have been done in this case, but we didn't do anything because we had already gotten a diagnosis of thrombus from the Doppler study, and therefore he was put on blood thinners and managed accordingly.
Sir, if I may ask regarding the similar case we had, and we suspected very strongly pulmonary embolism diffuse in the periphery. Is it possible that can be so severe and not picked up on CTPA that patient can die because of hypoxia?
Yeah, it is possible because he's definitely got pulmonary arterial hypertension.
Yeah, no, I'm talking about our patient. We had a similar patient.
Yeah.
We suspected strongly that she had pulmonary embolism and she was severely hypoxemic, but we couldn't pick it up on CTPA. But is it possible that patient can die with a normal CTPA because of embolism?
So this is what I'm telling you, that if the CTPA is normal, it does not rule out microemboli or small emboli in the periphery, and in any case would have been difficult to pick up if there were lung lesions. So that's why I'm saying that if you are not able to pick it up, then you either go for a VQ scan, or if you have a dual echo CT in your hospital, you can use that.
Right, sir. Thank you, sir.
Okay. Another case now, there is haziness in both lung fields. The diaphragms are indistinct. Why are the diaphragms indistinct? Because this patient is unable to hold his breath. It's not a bad X-ray. It's just that the patient is not able to hold his breath because of the severe involvement of both lung fields. So there's no point in blaming anybody for it. That is what the patient is suffering from. So when we did the CT scan again in this patient, you can see that there is bilateral bat swing edema. There is ground glass opacity in both lung fields, just sparing the periphery, but involving almost the entire lung field on both the sides. A small pleural effusion is also present. This was because of fluid overload. In this particular case, I don't know exactly what was the cause, whether it was a renal failure or what, but this is what a fluid overload with a bat swing edema would look like. And this is what the X-ray can look like. Haziness in both lung fields, no consolidation, no pneumothorax, and there is no evidence of scattered areas of parenchymal opacities. It's all diffuse opacities. You must think of pulmonary edema. And you can confirm it by doing the CT scan. So here you are. This was a patient of acute renal failure, ground glass opacities, no cardiomegaly, endotracheal tube was inserted. There was pleural effusion in the lung basis, in both lung fields. So this is what the X-ray looked like. So that's what, so all this, see, when you see this, it doesn't mean that it's only pulmonary edema. It can also be a diffuse alveolar hemorrhage. It can be a diffuse infection. It can be a onset of ARDS, where initially there's ground glass opacity, normal lungs, then ground glass opacity, and then consolidation. So ARD is actually a syndrome. So in the syndrome, the initial chest X-rays are normal. Gradually, the lungs become opaque, but you can see the bronchovascular markings through them. and subsequently they undergo consolidation, and then you develop a picture like that of ARDS. This is a 90-year-old male admitted with shortness of breath in the ICU. Same findings, bilateral peribronchial consolidation involving the upper and lower lobes. That is the trachea, mildly distended esophagus. There is calcification in the AV groove, atrioventricular groove. The opacities are mainly posteriorly located, so fits in with pulmonary edema and or bilateral chest infection. And the third possibility would be hemorrhage. Now, this patient's X-ray showed that he had a stent. He had evidence of coronary artery bypass graft. Sternotomy had been done. There is aortic calcification, so he has to have atherosclerotic disease. And his esophagus is distended and shows secretions within it. So whether the secretions were responsible for the lung lesions or whether there was cardiogenic pulmonary edema, that was the question. But since he had a sternotomy done, so we thought probably he has got cardiogenic pulmonary edema and the secretions are possibly incidental. So this is where we are. CABG was done and consolidation because of pulmonary edema, dilated esophagus possibly adding to the pulmonary edema findings, and you can see the infarct over here in the interventricular septum. A chronic infarct looks hypodense and can be easily picked up even in an NCCT. So this is what this patient had. You can see the coronary artery disease with evidence of a clip over there. Now, when you look at a chest CT scan of a patient of coronary artery disease or congestive heart failure, there are certain things you will see. One of them is smooth septal thickening. The septa over here, interlobar septa, they are smooth and they are due to septal edema or retained lymphatic fluid because it's not draining out. So you will see smooth septal thickening, you will see cardiomegaly, you will see a dilated IVC, and you will see thickening of the bronchial walls. So you got all the findings and with bilateral pleural effusion. So you got all the findings over here of cardiac-related pulmonary edema in this particular patient. So your CT scan will give you all the information that you need. You just have to look at them more carefully and you can make a diagnosis of cardiac, decompensation. Now, this is a patient who came to us with a history of, he was a soldier. He had come with a history of breathlessness. You can see that there are bilateral parenchymal opacities in both lung fields. He had been brought down from from Ladakh, or I don't remember which place, but it was a high altitude area. And there were pulmonary opacities in both lung fields. This is again pulmonary edema. And the pulmonary edema had been quite severe. He also showed an infarct over here in the left ventricular apex. And he was managed conservatively. He managed to survive. So this is what pulmonary edema can look like. And you must be able to interpret and diagnose it in the clinical context. You can see how large the RA is. It tells you that the pulmonary edema is causing severe RA pressures, right heart pressures. Now, here's a 27-year-old female patient. She came with acute short of the breath. She also had high fever and CCT was requested. So there are again scattered areas of consolidation in both lung fields. This is a typical picture of bronchopneumonia. There are solid areas scattered bilaterally, not lobar pneumonia. Lobar pneumonia would have been in the lobe. One of these lesions showed a central lucency. We also saw thrombus. Now, whenever a patient comes to us with acute shortness of breath, irrespective of what the clinician wants, normally they want a CCT. So we prefer to do a CT pulmonary angio, because in a CCT, what are we going to see? We are going to miss the pulmonary artery. We can always do a repeat scan after a few minutes. Then we can do the rest of the, we can perform that CCT. But we don't want to miss anything in the pulmonary artery because of the history of acute shortness of breath. She was only 27-year-old. And why was the fever causing so much of acute shortness of breath, when the lung lesions were not that many to cause the SOB? So we found a thrombus in this area in the right pulmonary artery. And we were, wondering why the thrombus was there, from where had it come. And, you can see the lung findings were deteriorating, the effusion had increased. And we carried down the scan into the abdomen. And what we saw was that there was a thrombus in the right pulmonary vein, right renal vein. You can see the thrombus very clearly in the right renal vein. The patient had actually, the lab tests were brought in, and the patient had acute pyelonephritis with a thrombus sitting in the right pulmonary vein, right renal vein, sorry, and which had actually gone into the chest and produced these findings. So it works very well. Whenever you come across a patient who has got acute symptoms, it is good to do a delayed arterial scan like we did in this case. We get the arteries, we get the aorta, we get all these structures, and you can subsequently, in fact, pull down your scan, and you can even see the upper abdomen at least, and it can pick up sometimes, these kind of findings, which enable adequate or proper management to be instituted. Another case, patient was admitted with a history of 2 to 4 episodes of hemoptysis. The studies of these scans are from day 1 to day 4. As you will see, that initially there was a small amount of effusion, then the effusion increased, and again, in fact, the lung at that time was a little loosened. Now it is almost completely opaque, hazy, probably completely surrounded by the effusion. So the effusion had increased, the mediastinum had shifted to the opposite side, as if you compare from the first scan, and therefore it meant that the patient was having a gradually increasing pleural fluid collection in the left chest. Now an NCCT was asked for. Now in the NCCT, this is the fluid in the left pleural space. That solid area is the part of the lung which is collapsed. That is fat in the mediastinum. That is the cardiac shadow. That is the part of the liver coming up. This is the right atrium, left atrium, aorta. If you look at the fluid, there is a focal area of hyperdensity, increased density as compared to the effusion. Now, this increased density is most likely due to a blood clot. So the patient had a hemothorax, and which was actually increasing. So an NCT is very important. Sometimes it gives you a lot of diagnosis. In fact, what I always do when I'm doing the CT scans, or when I'm supervising the scans, is I always do an NCCT. So I sit in the CT room, I see the CT scans, I do an NCCT, and if I find that the CCT is not going to be of any worth, I don't do it. But if I find that it will be needed, I go ahead and do it without having to ask the patient or anybody whether contrast is needed or not. I've also seen that in acute cases, there's no point in wasting time trying to get blood urea and creatinine and all that stuff. That can be done later on. So you can give a small amount of contrast and you can get away with it. And at least you get a diagnosis. The idea of a patient getting admitted in a hospital is to be able to get a diagnosis. If you're not able to diagnose it because you're withholding something, it's not right. Another patient, 50-year-old, cough with hemoptysis, X-ray done over a 3-day period. Now, most of these patients have either come from the ICU or they have been, the interventions has been involved in these cases. And so a combined team effort has been there in these cases. So you will see that the effusion increased over a period of time, over 3 days period. Endotracheal tube was there. The right lung was quite loosened as compared to the left. It means the right lung was getting the ventilation. The left lung was not getting ventilated because no air could get into it because of this opacity over here. So another thing I want to ask you or request all of you is that whenever you come across a patient who's got an opacity in the chest, you must always start with an ultrasound. Make sure that it is not consolidation. Only if you are sure that there is effusion, then think of putting in a chest tube. Very often it happens that they put in a chest tube and get nothing. That is because there is a completely opacified lung because of consolidation. Here, what we are seeing is opacified chest, opacified hemithorax. How do we know that there is a lung which is opacified or whether it's a pleura which is opacified? The chest X-ray does not give us this inference. So you must use ultrasound, and it's really very wonderful investigation, which you should use as frequently as possible, and you will be rewarded by using ultrasound. So this patient had an effusion, which was increasing, and I gave you the history that the patient was having hemoptysis. So what we found was that there was an aneurysm of the left pulmonary artery, which was continuously bleeding into the left chest, because of which the hemothorax was increasing, and it had increased rapidly to collapse the left lung. Very important to think of these things, because it saves the patient, it saves a lot of time and energy, and you don't go around dilly-dallying. Do not delay CT scans if you think that they are necessary. Delaying a CT scan can sometimes be very detrimental to the patient. Coming to another case, very often we come across these kind of cases, completely opaque chest. In fact, in this patient, the right lower lobe was opaque. There were focal areas of atelectasis in both lung fields, and there was a radio-opaque density in the right lower lobe. So what was this density? So when we look at it carefully, you see there's a very dense structure with a central lucency. This is a tooth. This patient had a loose tooth which had fallen into the right main bronchus and come into the right lower chest, and was associated with superadded infection and consolidation. So these things are also there. You can NCCT can tell you very easily what the finding is like, and they are very rewarding actually when you look at these kind of cases. So summing up, many of these cases from the ICU are tough to diagnose, and they often require several investigations, a lot of thinking on part of everyone, including the radiologist. And then only, these tough nuts can be cracked, and you can be rewarded by a good diagnosis and proper management. So with that, I hope I have been able to show you some of these interesting cases which we had in our collection. And if there are any questions which you would like to ask, I'm open to the questions. So thank you very much.
Thank you, sir. Thank you very much. Can you stop the share screen, sir?
Okay.
Fine, sir. So if the audience has any questions, please put them up. Thank you, sir, for sharing your experience. Wonderful CTs and wonderful cases. So while we wait for any questions from the audience, maybe I can just put up some questions, sir. So first, sir, can the CT be normal in a patient with lung disease?
Sorry, a CTPA?
Can the CT chest be normal in a patient with lung disease?
Yes, of course. Because a CT scan chest is a two-dimensional depiction of a three-dimensional structure. So it is very easily possible that a CT chest would be normal. This happens very often when there is a mediastinal pathology, because the mediastinum is a large structure, and we are seeing a very narrow area of the mediastinum in the chest X-ray. So a CT will not show mediastinal lesions. And again, in the lung fields also, there can be lesions which can be obscured by overlying ribs, and the density may not be very high to be able to be picked up on the chest X-ray. So a CT scan will definitely be useful in these cases, and the X-ray can be completely normal.
Can the CT be normal, CT chest, in patient with lung disease or mediastinal disease?
CT being normal in the case of no, it's not possible. It's not generally not possible unless and until the patient has been, it can be misinterpreted, but very unlikely to be normal.
So in emphysema, COPD patients, can the CT be normal in the patients who don't have advanced COPD, mild to moderate COPD?
No, it will not be normal. You can look at the trachea. The trachea will be saber-shaped.
And what about the lung fields, sir? Like any cystic shadows and
the lung fields will be large. There'll be increased lucency. There'll be paucity of vessels. There'll be displacement of the vessels, and there'll be areas which not show any vessels. So the X-rays CT cannot be normal.
But the confirmatory and the first sign is a saber-shaped trachea, you said.
Saber, S-A-B-R-E.
That will always be there, sir.
Always, because the cartilage collapses.
Okay.
If a patient got COPD, the cartilage gives way and it starts collapsing. That is one of the reasons why these people become breathless. They have a sort of a check valve mechanism which develops. So the lungs become large and the diaphragms go down, because the cartilages, have collapsed and the trachea is not able to expand during expiration.
So apart from the saber signs, sir, can you, will there be always signs like small cystic shadows or thickening of the bronchi?
Yes, you can see small, when you see cystic shadows, you will find that it's actually a central lobular opacity. In central lobular opacity, generally you do not see walls. So you can't call it a cystic shadow. Sometimes what happens, because lots of central lobular opacities are close by, the intervening alveola, they come together, and that forms a lot of sort of a wall, and it can look like a cyst. So cystic shadows will be seen, and they are actually central lobular opacities which are closely approximated.
So then sometimes we get these cases, where we suspect acute bronchitis with, bronchiolar constriction. So
Yes.
X-ray will not reveal anything. So is this
No,
picture
no,
for
no.
CT?
Yes, yes, you can see, you can see the walls of the bronchi become thick. Normally they are very thin. So if they become thick,
Okay.
and that is actually you
And you
can
will
see
get tree in bud also in this? Tree in bud appearance may or may.
the thin bud is a feature of bronchiolitis.
Okay.
It's a feature of secretions of fluid or what you call cells accumulated within the bronchi, in the peripheral bronchi. So it is only a feature of accumulation of fluid or cells. It can be due to any condition, but you can see them if there is infection or retained secretions.
So then just coming to the last point, so what about this? There's something known as pruning in pulmonary hypertension. So what exactly happens in that?
Yeah, peripheral pruning.
Yeah.
Peripheral pruning means that the periphery of the lung has expanded because of small airway involvement. So air is trapped in the lung periphery, and the peripheral vessels are constricted because of the compression from the outside air. Also, whenever the patient has got hypoxic, there is vasoconstriction. So there too, you will find that the peripheral vessels will not be seen.
Right, sir. Okay, sir. Thank you, sir. I think there are no questions from the audience. It was a wonderful session, and I think it'll be great learning. We'll put it up on YouTube for everybody to see also, and I will share it with you. Thank you, sir. Thank you very much.
Thank you very much.